Hi guys, Josh Lampert here, plastic surgery. Today we're going to talk about breast implant problems. And in my practice in Miami, Florida, we see a lot of breast implant problems from around the world. The two most common problems that we see in patients who have breast implants are capsular contracture, which this diagram shows, and bottoming out, which this diagram shows. And these are two entirely different things, but sometimes we see them in the same patient, like this patient here. She had capsular contracture that was pulling up the implant on the left side, and on her right side, she had bottoming out. The implant was falling low. So how do these things happen? Well, coming back over to the diagram here, let's start here with bottoming out. So we had in our Breast Surgery 101 course talked about the importance of the breast fold, and one way you can get into trouble with bottoming out where the implant falls onto the abdominal wall is if the breast fold was either cut or if the patient has very loose skin with loss of elasticity and that fold is weak. Most commonly we see because the fold was cut during the initial operation, the other plastic surgeon was trying to put in a big breast implant or was trying to lower or change the position of the breast fold. So if we look over here at the anatomy drawing that we have here, just to kind of refresh, here's our nipple areolar complex, here's our breast tissue. This patient in particular we drew with a submuscular implant, so here's pec major muscle. The green is the pocket, okay? So that's the pocket and the capsule that forms. The implant, every implant encapsulates, your body encapsulates it with scar, and that's what we call the capsule. So with a very large pocket or during the surgery, if this fold was cut, the implant can fall down onto the abdominal wall, and we've lost now domain of the breast. So now the implant isn't really sitting under the breast where it's supposed to, it's sitting on the abdominal wall, and it creates a severe deformity in a lot of patients. The other thing that happens with these patients is this can continue over time to get worse and worse because this skin is very soft, and just like women with pregnancy, their skin stretches, the same thing over time with the breast implant. Typically, these patients have very soft capsules. The capsule is very thin, it's weak, it's not very strong or rigid, which is very different than capsular contracture, which we'll talk about in a minute. The problem is once this breast fold has been severed or cut, it's almost like a ligament that secures the skin down to the chest wall. So once it's been cut, it's very hard to reconstruct that. And we can do it with a number of ways, trying to use the patient's own tissue, using an artificial mesh, or even using a collagen that's taken from cadaver and animal sources. But either way, once this happens, it's very hard. So frequently, if patients have a slight discrepancy in their breast fold, a little bit of asymmetry, we accept it. We don't try to adjust the breast fold too aggressively because that can lead to this problem. You can also see this problem in patients who have very poor quality skin. For some reason, some patients have much weaker, thinner skin that stretches out a lot more. So this can happen in those patients. And to be honest, those patients are some of the hardest patients to treat because you can get this implant back up and reconstruct this breast fold, and the skin will just stretch out and the tissues will just stretch out. So some people that have those problems, cutis elastica, there's a couple other actual diseases, but some people just have stretchy skin. Kind of opposite of that almost is when we see implants that are kind of up in the chest. Going back to this photo here, this patient, she has capsular contracture on her left side, and you can see the big difference. She's got bottoming out on the right side, that breast has fallen way down, way below where it's supposed to be, and then she's got pretty severe, painful capsular contracture on the left side. So what happens a lot of times with capsular contracture or an implant that's very high up, almost up to the clavicle, two things. One could be the pocket was made too big, too high, that's one way, but more often what we'll see, especially if a patient says the breast got worse over time, is that the capsule will get thick and hard over time. And this is the natural evolution of the capsule. Your body feels that the breast implant is a foreign body, a foreign object, and it wants to create scar around that. And over time, that scar gets thicker and thicker and thicker. In certain patients, this takes 20 to 30 years to happen. In other patients, we don't really know why. It happens pretty soon after surgery. We're starting to better understand how to avoid capsular contracture, but to be honest, we're still learning a lot at an exponential pace. So things have changed a lot over 10 years, and it's still a problem that we face. But kind of going back to the anatomy, this capsule gets thicker and thicker and thicker, and it ends up pulling the implant up into a position that is painful potentially and doesn't look good. With capsular contracture, there's 4 grades of capsular contracture. The ones that are most severe, grade 3 and 4, mean that the implant's being pulled out of position, and we call it a grade 4 if you have pain. So if you have breast pain, you have a grade 4 capsular contracture. This patient that we were talking about and showing her photo earlier had both problems. But what's difficult is this capsule, we almost look at it like parasitic. We almost look at it like trying to cut down ivy off the wall. If you leave behind this capsule, the chances of this capsular contracture recurring is much higher. So typically when we have a patient with bad capsular contracture, we try to remove that entire capsule. We don't want to leave behind any of that capsule. If for instance, some surgeons will try to remove just a piece of that capsule, what will happen is that capsule over time will grow back together and kind of reestablish itself as a thick capsule. So currently, to try to repair this problem, we're usually removing the entire capsule, which also causes a problem in that you can have a very large breast pocket. So going back to the photo of the patient prior, we did a smaller implant, slightly smaller. If we tried to go much smaller, it would be hard to hold that implant in position due to the size of our pocket. It becomes more work with the surgeon. So sometimes as a surgeon, we have to use meshes or other alternative means to try to hold that implant in position. But you can see how these are 2 different problems, and these are the most common problems, and they're both very difficult. And revision rates are extremely high with these patients. So when you open up the textbook and you read what's the chance of correcting this operation, some of these operations have as high as a 20% failure rate or higher if they come back and have had multiple problems. Typically, we can improve these things with surgery. We may not make them perfect, but we can significantly improve them with a revision operation. But when problems recur and come back over and over again, sometimes you have to sit down and discuss with the patient, what's the next step? Are we gonna try a different technique? Are we gonna use a mesh, which has some risks as well? Are we gonna use a cadaver collagen source from a human or animal source? So sometimes also we're doing a little bit of a breast lift, which I kind of show you in the next patient. And she's got some bottoming out on one side and some severe asymmetries. She also wanted smaller implants. You can imagine the implant stretches out the breast tissue significantly. So if you want to remove and go to a much smaller implant, sometimes we're a little bit more forced into a breast lift. She has a wide areola spread, and the prior surgeon was trying to do a breast lift just by putting a scar around the areola, which is called a donut mastopexy. These typically fail if you're trying to do any significant lift. So here she is about 4 months out, and we've replaced with smaller implants. They're only 180 cc's. I think she went from about a 400 cc down to a 180 cc implant. The benefit of the implant is it allows her to have a better shape of upper pole fullness and more roundness to the breast. So you can see also she has a lollipop lift scar, and that vertical scar is always visible, but sometimes it's almost imperceivable, which is the goal that we're going for. And I have some of these, I'll look in the bright light in the examination room and I can hardly see them, and that's always the goal, but other people do have thicker scars. But if you're doing a significant either breast implant removal with stretched skin, or you're doing an implant exchange to a much smaller implant, a lot of times we have to do a simultaneous breast lift.